Morning. Welcome to the upper GI bleeding course. Okay, so let us talk a little bit about background of upper GI bleeding. As you know, acute upper GI bleeding is a common medical emergency which has got about 10% in hospital mortality rate. Nearly 100 to 150 patients per 100,000 get admitted with upper GI bleed per annum. And in the UK, about 70 to 85,000 people are admitted with this problem. And if you translate it, it's about one GI bleed every 6 minutes. Despite changes in management, mortality has not significantly improved over the past 50 years. And currently, if you look into any big series, the mortality is around 10%. Majority of the patients admitted with upper GI bleed are secondary to peptic ulcer disease, about 80 to 90% of them, and the rest being variceal bleeding. And we are seeing an increasing trend toward variceal bleeding now. So let us talk about the key issues in GI bleeding. One of the first things is majority of the patients can be assessed and safely discharged. So we need to have a good triage system of how we can safely discharge patients who have been admitted with GI bleed, and then admit the ones who really need to be admitted and do an endoscopy. And the issue about the use of anticoagulation, antiplatelet therapy has become even more important now because of so much of cardiovascular comorbidity, and many of our patients are on either warfarin or the newer anticoagulants, or the newer antiplatelet agents like clopidogrel. So that is an issue which we will discuss as well today. And then the use of PPIs before, during, and after endoscopy is something where more evidence that has come up, and we will discuss that as well. And now there is a bit of a controversy on the use of PPI and clopidogrel, and the controversy being that it might reduce the efficacy of clopidogrel, but we'll touch on that as well. And more importantly now is the amount of blood transfusion that can be given to these patients. And then when endoscopy fails, what else you do? So first of all, we need to identify who is at risk. As you know, patients who are frail, elderly are always at risk of GI bleeding and mortality from it. Patients with multiple medical conditions, cardiovascular comorbidity in particular, smoking and alcohol can also add on to it, and also the use of drugs like non-steroidals, aspirin, and anticoagulation. I think the first thing to do is to risk assess these patients. And two scores have been very useful, and there's been approved by the recent ESG upper GI bleeding guidelines as well. One is the Rockall score, which is now over 10, 20 years old, which has been validated. And then more recently, the Glasgow Blatchford score, or the GBS score, which has undergone quite vigorous validation as well. So let us talk initially about the Rockall score. So the Rockall score is based on age, comorbidities, presence and absence of shock, and this is done before the endoscopy, as you can see in this slide, and a maximum of 7 points can be derived with this pre-endoscopy score. And once you've done the endoscopy, then you can have the final score, which is maximum 11. And now, after you've done the endoscopy, you have the diagnosis, and then also you have the signs of major recent bleeding from the endoscopy, and also the presence or absence of malignancy in the upper GI tract. So once you've done that, you have a full Rockall score. So what is the significance of using the Rockall score? Basically, based on the scores, we can predict the mortality and the rebleeding in these patients. So in this slide, you can see as the Rockall score goes up, then you can see the mortality goes up, and comparing to patients who did not have any rebleed and those who had rebleed. Generally, the rebleed goes up when these patients do have higher Rockall score as well. So when the Rockall score goes nearly 7 or 8, then there is 50% chance that this patient may not survive. The next is the Glasgow Blatchford score, or the GBS, and this is something which we use to predict need for intervention or mortality. And this is easier than the Rockall score because this can be done before the endoscopy, and it's a final score, and it's based on the blood counts, and based on the blood urea, it's based on the blood pressure, pulse, and the presence or absence of any other comorbidities like liver disease, cardiac disease, and the presence and absence of obvious melena or hematemesis. If you have a GBS score of 0 or even 1, these patients do not need an endoscopy or do not need even a hospital stay, so they can be discharged home and then brought back for an outpatient endoscopy, whereas patients who have a higher score will need a hospital admission and prompt endoscopy and resuscitation and treatment. So is there a big difference in using one or the other? If you look into this slide, you can see that once you have a full Rockall score, that is pre and post, it's almost equivalent to the GBS, although the GBS seems to be slightly better than that. So you need to have both pre and post Rockall as well as a GBS that gives you an overall picture of how the patient is going to do when you admit these patients. Now, this is a slightly old slide, but it gives you an algorithm of how you assess and treat patients when they come in with GI bleed and when they are on antiplatelet therapy, because this is, as I said before, becoming an issue now with more of cardiovascular comorbidities and the patients having MI, coronary stents put in. So the first thing to do is to see whether the patient is exsanguinating or not. That is, if the patient is hypovolemic and shock, then obviously you need to trigger off the liberal blood transfusion protocol because these patients are at higher risk of acute myocardial infarction and death. However, when the patient is not shocked, then this is where we need to be careful of how much blood we are going to be transfusing. There have been quite a few discussions about it recently, and a good randomized controlled trial from Barcelona showing that restrictive transmission reduces morbidity and mortality in these patients compared to a liberal transfusion. More recently, there has been another trial in the UK, which was more of a feasibility trial of restrictive versus liberal transfusion, and the pointers are all towards restrictive transfusion to around 7 or 8, and you transfuse only if it is more than that. And once you've done that, the patient needs to be admitted to a high dependency unit, and there should be a close liaison with the cardiology team, and prompt endoscopy has to be done within 24 hours, because endoscopy is the only investigation that will give you an idea of how risky this patient is going to be in managing. Because if you see a high-risk ulcer, then it needs to be treated, and then the question about withholding anticoagulation needs to be discussed at the time. And if you don't find a high-risk ulcer, then it is fine to continue with anticoagulation or antiplatelet therapy. The next issue to discuss about is the use of PPI or proton pump inhibitors along with clopidogrel or the newer antiplatelets. There has been concerns about decreased efficiency or efficacy of the antiplatelet agents, but I think the bottom line is that we need to triage these patients based on the risk scores, what I said, and the endoscopy, and then if the patient truly has a high risk of rebleeding and the patient has a high risk ulcer, then antiplatelet agent has to be stopped temporarily for 24 hours, 48 hours with close discussion with the cardiologist, and the intervention has to be made. On the other hand, if they do not have any high risk features, then it should be continued to reduce the cardiovascular comorbidity. Continuation of antiplatelet agents like aspirin is also been controversial, especially in the past. Patients who had peptic ulcer bleeds were asked not to take any aspirin at all. But this study has clearly shown that not giving them aspirin increases the mortality from cardiovascular disease, although continuing them can produce recurrent bleeding. But now using concomitant PPI will avoid this, and I think it is safer to continue with low-dose aspirin in these patients. The use of PPI, let's talk a little bit about the use of PPI before and after endoscopy. So intravenous omeprazole has been used in patients who have been admitted with suspected upper GI bleeding before the patient had an endoscopy. The key message from this landmark paper in the New England Journal from the Hong Kong group is that if you treat them with intravenous PPI omeprazole, these patients do not have a high-risk endoscopic features that needs to be treated. So essentially, infusion of high-dose omeprazole before endoscopy accelerates the resolution of signs of bleeding and ulcers and reduces the need for endoscopic intervention, which again helps in managing these patients, although it has not shown a big difference in the mortality or outcome. Now, when we do an endoscopy for these patients, as I said before, we need to risk assess the ulcer. So here in the slide, you can see on the top here on the left, which is a spurting blood vessel which needs to be treated. And these patients have a nearly 50 to 60% chance of rebleeding. And these are the high-risk patients which we need to focus on. Next, you will have patients who have a visible vessel as seen here, and these are again patients who needs to be, this is for us 2A, and these are patients who needs to be treated as well because they have a higher chance of rebleed, which is about 40%. And now the 2B is the adherent clot. When you see an adherent clot, it is always a concern whether there's going to be a high-risk blood vessel underneath it. And there are differences of opinion how you would manage these patients. Ideally, these patients should have their clot removed to see what is happening underneath and then treated. But if there is an adherent clot and if it doesn't come away with a strong irrigation, then there are endoscopists who would not disturb it and then provided the patient is going to be having intravenous PPI. The current ESG guidelines says that if it is appropriate to remove the clot and then treat it. On the other hand, if it is an adherent clot and you decided not to remove the clot and treat it, then you should be treating these patients with high-dose intravenous PPI. And now, finally, the low-risk ones are the ones with a pigmented spot or a clean-based ulcers. The risk of rebleeding is very low in these patients, and these ulcers can be left alone, and these patients can be treated with oral PPI, and maybe even discharged after 24 or 48 hours. So what are the treatments what you would use for these patients? Traditionally, adrenaline has been used, but now we know that just using injection of adrenaline alone is not good enough. So it has to be added on with a second modality. Ideally, it should be a contact thermal modality like a heater probe or here a bipolar probe. Here it has got a needle as well as a bipolar probe here, so that in one accessory you can do both inject the ulcer around the ulcer with adrenaline and then cauterize it with the bipolar probe, which is quite handy to do. And the other modalities are using clips. This is a standard two-prong clip. You can also use the Ovesco, which is a bit more a stronger clip that can be used. And it's ideal should be to use a therapeutic gastroscope, which has got a water jet as well to clean and see and then treat them. More recently, we do have the hemostatic spray, inert material, and this is the one called Hemospray, and there are others as well in the market, but these things are undergoing evaluation, and at the current time, they may not be recommended as a first-line treatment. Maybe we can use this as a rescue treatment if you fail with any of these other interventions. But the key message is here is that use dual therapy if you're going to do injection, and if you're going to do only mechanical, then you're allowed to do a single modality therapy. So the evidence now comes from quite a few trials, and this is the meta-analysis looking into addition of a second endoscopic modality of treating high-risk ulcers. And as you can see, it reduces rebleeding from about 18 to 10%. It reduces emergency surgery from 11 to 7%, and reduces mortality as well from 5 to 2%, which is pretty impressive results of this, and hence now the recommendation of using dual treatment. Now, what happens after we have done all these things? Ideally, these patients should be monitored in a high-dependency area, and more importantly, these patients should be on an intravenous omeprazole or PPI infusion for 72 hours. Again, this study, which was a landmark study published in 2000 in the New England Journal of Medicine, comes from the Hong Kong group, where they clearly showed that the rebleeding rate is lessened if you are going to be using intravenous PPI post-endoscopic intervention, and that's an important message here. Now, what happens if this fails? This is a scenario which we are not unfamiliar with. About 10 to 15% of these patients will fail endoscopic treatment, and this is when now we need to think what else to do. So traditionally, we've been offering surgery to these patients, but we know now that interventional radiology has come a long way when it was first described in 2002, and now it is now a standard practice for these patients to have angiogram and embolization when endoscopy fails. In a recent audit in the UK, we identified that in really bleeding patients, about 20 to 30% of them went on to have surgery who had a higher mortality, about 30%, compared to people who had interventional radiology, which was only about 10%, and repeat endoscopy was about 20%. So clearly there is a role for interventional radiology, especially if you fail with endoscopic intervention. And who should we operate? As I said, we are hardly operating on patients who have peptic ulcer bleeding, and we would do it only if the patient is exsanguinating and you're not able to see much with your endoscopy, and you don't have much time for the patient to be transferred into the interventional radiology suite, and you are doing an endoscopy in an operating theater, then you might as well operate on these patients. And I think it's clear that you should have the surgical team backup when you are scoping patients who are hemodynamically unstable and having a massive GI bleed in an operating theater, so that you intervene quite quickly. As I said, but this is becoming a rarity these days. And finally, you should not forget that the cost of mortality in patient peptic ulcer disease is just not the bleeding. More often, the patients die of other issues, especially cardiovascular and respiratory. Patients do aspirate, they do develop ischemic heart disease and myocardial infarction because they have other comorbidities. So it's important that the patient is adequately resuscitated. All the other backup facilities are available. The general medical management of the patient is the key here, and that should also have concentration. It's just not good enough to do an endoscopy and stop the bleeding, but it is more of a holistic approach to these patients. Finally, my last slide, the upper GI bleed management is an algorithm. You need to first assess and resuscitate. Risk assessment gives you an idea of which patients will not do very well, who will need more intensive care, and those patients who can be discharged using the risk assessment scores, what I mentioned earlier on. And finally, you manage them. The majority of the patients will benefit from endoscopic intervention, and if endoscopy fails, then intervention radiology, and very rarely we will be using surgery. Thank you very much.